So, do you want to tell us about your presentation, just in general? What is the main? There was a question for you there in the chat. Any good books that you will recommend for pediatric pelvic tumors?
Actually, it's scattered chapters almost everywhere, and most of the good information comes from papers and case series. There's no specific book that I can really tell people to use for the pediatric tumors.
Okay, so you cannot recommend anything in particular?
No, I don't think so. Not yet. I don't think there is some book that is really enough for everything. So I think you have to search all the time.
Okay, right. So I'm just having a little bit of a problem locating and starting your presentation, but it is coming anytime now. Yes, so we are there. Sacral fractures. Okay. Great.
Good morning. I'm Abdelfatah Saoud, Professor of Orthopedic and Spine Surgery and former Vice President for Education at Shams University and past President of the World Spinal Council. This is the commonly used Dennis classification for sacral fractures. Zone 1 fracture involves the sacral ala lateral to the neural foramine. Zone 2 fractures involve the neural foramine, while Zone 3 is in the canal, medial to the foramine. Zone 3 fractures commonly have a transverse limb with the longitudinal fracture, and this is a subclassification on the amount of displacement this fracture can attain. And there are a lot of morphological patterns that this fracture can attain as well. And this is a very common classification and a very important one. The Isler classification of the longitudinal fractures of the sacrum that relates the fracture line with the lumbosacral articulation. If it is completely away from the articulation or partially related or totally related to the articulation, it's very important, especially if bilateral, because it tells you if there is a lumbo-pelvic dissociation, which is a very, very important instability that needs to be dealt with. Those are the indications of surgical treatment of sacral fractures, especially the expanding retroperitoneal hematoma, because fixation in this case causes tamponade of this hematoma that's forming and rapidly growing and threatens patient's life. If there is more than 1 centimeter displacement, if there is a soft tissue compromise, because there is usually a lot of affection of the soft tissues around the pelvis and the spine, and the more stability you can give, the more chance for soft tissue to heal. If there is displacement or persistent pain during conservative management, and if there is neurological compromise, especially the bladder and bowel disturbance in form of incontinence and L5 or S1, 2, 3 motor weaknesses. This is how the expanding retroperitoneal hematoma might look like, and this is the usual soft tissue appearance around the polytraumatized patient with fracture of the sacrum. Surgery aims at stabilization and decompression. Decompression that can be direct or indirect, and it seems on long term there is no big difference. But my personal bias is I tend to directly decompress incomplete neurology to give best chance for relief of the neurological manifestations, and for type 1 and type 3, where in the transforaminal type of fractures, I tend to do indirect decompression, as I found that the direct decompression in this case causes more injury than resolution of the manifestations of neurological affection. So if you tend to stabilize, you need to put two very important biomechanical concepts in mind. First one, the lumbosacral pivot point, which was described by McCord in 1992, and it's the axis of flexion and extension at the lumbosacral junction. It lies, this is the point that I've drawn here. It lies in the back of L5S1 disc. And for any construct that crosses the lumbosacral junction, only those devices that pass ventral or at least partially ventral to this point provide a significant biomechanical advantage regarding the rigidity of fixation. And these are the fixation points that we are going to discuss. These are the iliac screws. These are some of the sacral screws, and our parameter here will be this is the pivot point and how much anterior any one of those constructs can pass related to the pivot point. And if it is completely posterior, like those sacral bars that I will describe in a few moments, why they failed always. Anything that is completely posterior to the pivot point have question mark on the rigidity of fixation, and thus on the possibilities of union. The second important biomechanical fact that you have to deal with while trying to choose a fixation point around this area is the fixation zones described by O'Brien. The blue area is zone 1, which is S1 vertebral body and cephalad margins of sacral ala. It's a place of reliable method of fixation around this area. While the green area is zone 2, inferior margins of sacral ala, S2, and area at the tip of the coccyx, which is least effective for bone stop anatomical constraints. And zone 3, which is the yellow area, both iliac bones, large biomechanically efficient anchors. So these are the same zones again. We will surf with the methods of fixation around the sacrum, and starting with the iliac screws. We start putting the iliac screws from the posterior superior iliac spine area. We used to put them from the tip. They become very prominent, so we started putting them medial. Now we are putting them most medial and most inferior posterior superior iliac spine, so they are less prominent and covered by the posterior superior iliac spine, or at least buried inside the posterior superior iliac spine. You pass towards the greater trochanter and between the tables of the ilium, getting fairly long screws, and they are having a significant part of those screws in front of the pivot point, so they are very effective around this area. But how to use them? They can be part of lumbopelvic fixation that will fix the sacral fractures, buttressing them together, causing rapid union, and this is especially if there is dissociation between the lumbar spine and the pelvis that I've described in the Isler classification. This is going then to be a very effective method of fixation. This is another way of connecting the lumbar fixation to the iliac screws. And this is especially directed, as I've just said, to those fractures that cause lumbopelvic dissociation, especially if bilateral. And it's very effective also when there is displacement of the sacral fracture because of the configuration of the fracture that combines longitudinal fracture and a transverse flexure line. This is an example, one of my cases, 20 years old soldier from Libya, fall from height sitting, admitted 72 hours post-trauma, incontinent for urine and stools, partial foot drop bilaterally, sensory loss around the saddle area. And this is how the fracture looks like, with a lot of displacement of the sacral fracture with the neurological affection that I talked about. And you need to be aware that this means if there is contents, like in this case, that there is bilateral affection of the nerve supply for the bowel. Those are the other cuts of the CT that shows the significant stenosis around the fracture site. This is the method of fixation that I use, full decompression of this kind of fracture, and I do both lumbo-pelvic fixation and pelvo-pelvic fixation or ilio-ilial fixation, and in my hands this causes the best results. And this is the lateral view after decompression and fixation. This is intraoperatively. I avoided fixation here at L5 because there was fracture of the pedicle here. So this is L4, this is L5. These are two iliac screws. One of them is used for the lumbopelvic fixation and the other one for ilio-iliac fixation. This is the wide decompression. Another case from Libya, gunshot exit, grade 1 to 2 paraparesis, presented 30 days post-injury. Same approach with great improvement. This does not mean that this method of fixation is not having any drawbacks, and it's better to avoid it when it's not needed, because it restrains lumbar and thus waist movement that might cause early spondylosis or adjacent segment degeneration, especially if lordosis is lost. So it has to be kept with its indications. Before talking about the most innovative part of my talk, the traditionally used methods for sacral fixation rather than the lumbopelvic fixation are the iliosacral screws. Actually, they are sacral screws that takes the advantage of passing through the iliac bones, and then in this void between the sacrum and the ilium, and then pass as a sacral screw, and it fixes those longitudinal fractures in a very good way. But there are some very important points to talk about here. Without having perfect reduction before putting any of those screws, those will definitely pass in the wrong direction. And there is no much leverage that you can use those screws for, because they are not very strong screws. You cannot use them as a method of reduction. So you are only doing traction of the lower limb. And even if you get perfect reduction, you need a lot of X-ray image during the operation to make this screw in a perfect position. So it's a big hazard for the surgeon, not only for the patient. This is the trapping of the patient. You definitely need anteroposterior inlet and outlet views during this surgery. This is how the inlet view looks like. This is the insertion method. Sacral plates, they are not minimally invasive, and they need a lot of dealing with the soft tissue, which is already traumatized, and only very few points that you can put screws through sacral plate to serve well, passing in front of the pivot point, so they are not very effective. These are the old sacral bars with nuts on both sides. They are minimally invasive, but completely posterior to the pivot point, so they usually failed. So this is the most innovative part that I've done with the fractures around this area, modifying those sacral bars into bars that are connected to iliac screws. So in this way, the iliac screws are passing in front of the pivot point and completely embracing the pelvis, and did a lot of change. This is the idea of dry bone. And if you do this with a couple of iliac screws on both sides and 2 bars, this is the idea again. Very minimally invasive, and I called it the internal fixator because it's going to work permanently, but it it is introduced in a very minimally invasive way, as if you are putting an external fixator. This was the first fracture that we used this for. We put first a small plate through a finished steel incision and put a couple of iliac screws to fix the fracture. This was truly minimally invasive, but we used two approaches, anterior and posterior. We modified this even for those open hook fractures, and we can now just use a belt to cause abduction and then doing the ilioiliac fixation from posterior only, and it works very well. This is the belt below the posterior superior spine area, and this is how much reduction and fixation you can get. Another case, result. Even with those comminuted multiple fractures around the pelvic area, perfect reduction and full union can be done like this. We studied this device biomechanically at the University of Toledo, myself, Lisa Ferrara, Andy Wakefield, and A. Joel. And in longitudinal sacral fractures, it is even stronger than intact specimen. And we showed this as an oral acoustic presentation in the ISAS in San Diego in 2015. This is our long-term results, longer-term results, minimum 3 years follow-up for this minimal axis fixation longitudinal sacral fractures. It was published in the World Neurosurgery in 2018. Prospective done in Ain Shams University on 50 patients. Bullman clinical scoring with very, very good results, no poor results at all. Even return of work for those patients was very good, with 66% excellent final results, 18% good, and 16% fair results. We did not need in our series to remove any screws for prominence. We are even using this ilioiliac fixation now for patients who need sacroiliac fusions, putting them minimally invasive, causing compression. In some cases, we use BMAT or grafting to cause more rapid fusion. It works very well as well. This is an example of using this ilioiliac fixation after partial sacrectomy for sacral tumors. This is a chondrosarcoma case. It caused both L1 and sacral root compression, and it was almost completely removed surgically, with very good release of neurological infection. And this is the ilioiliac fixation afterwards, follow-up X-rays. And the ones are accepted for such a huge tumor. Thank you, and see you in Bandung in December of this year.
Thank you so much, Saoud, and it was a great presentation as usual.
Thank you.
I think there is no questions for you from the chat. It is very, very specific area that you are working, and maybe that's why. But surely, if there are any questions, we will direct, and then we will we'll get back to the people asking questions. And if they don't have questions, you have prepared questions for them. So this will be now part of a questionnaire that will be sent to them. And they have to try to answer it to get their certificate. Might not be right, and if it's wrong, we will get them the correct answer, but they have to try to answer it first to get their Royal College certificate.
Perfect. Thanks for inviting me.
Thank you. Now, so I think the first morning session is